All right, we are now recording and you're able to start.
Perfect, thank you. Good morning, good afternoon, everyone, wherever you're located. Just wanted to mention a few logistics before we get started. If you want to communicate with each other, there's a chat icon along the bottom of your screen. You can click on there and you can either select to speak to all panelists and all participants or attendees, or just to the panelists. So please send any messages there. If you have questions for Dr. Gardam, please click on the Q&A icon along the bottom of the screen. Enter your question there, and then we'll have some time at the end to go through questions. And my colleague, Dr. Jaason Geerts, will be answering or vetting those and moderating the questions towards the end of the webinar. For follow-up from today's webinar, we're going to be sending everybody, all participants, an email tomorrow that will include a link to the recording of this webinar. It will also include a link to a short survey on how we might further support health leaders, health professionals through this pandemic. So please take a minute just to send us your ideas and your thoughts when you get that survey link. And also we'll be including any resources that are mentioned today. We'll be including those in the email tomorrow so that you know that they're coming and you don't have to worry if you don't hear it clearly today. So just a quick update on what the college is doing to respond so far to support our membership. We're doing this webinar and we hope to continue to do webinars on timely topics as this changes over time and almost by the hour. We're supporting our 20 chapters by switching their AGMs to holding virtual AGMs and transitioning events where possible to virtual ones if the participants aren't too busy. But as you all know, it is a very busy time and priorities are shifting. We've created a Twitter list to which you may subscribe. It's called COVID-19_health leaders. And that includes up-to-date COVID-19 information and stories shared by health workers, leaders, and organizations. The CCHL's news page has links for not only the Twitter list, but other links as they become available, including blogs, tweet chats, and so on, that are current and relevant for people working in healthcare. So moving on to the why you're all here, I will increase my volume a little bit if that helps. So Dr. Michael Gardam, Chief of Staff at Humber River Hospital and an infectious disease physician. He's an associate professor of medicine at the University of Toronto, master's degrees from McGill University and University of Toronto, and is a Canada in infectious disease. And I'm also really happy to introduce Michael is one of our newest holders of the CHE credential, the Certified Health Executive credential. So hi, Michael. Thank you for taking time out of your unimaginably busy schedule to be with us today. So we have framed our questions. We're hoping to have a bit of a dialogue, but we have framed them in the LEADS framework just to help guide, hopefully cover as many topics as possible. One of them being starting off around leading yourself through this pandemic. You're being pulled in 100 different directions. How do you manage that?
Yeah, that's a great question, because I certainly feel like I'm pulled in 100 different directions right now, I can tell you. I think, in fact, if we were to have held this one day later, I would have had to have bailed on you, because there's so many things going on right now. And you're being pulled from multiple different groups, so within the hospital, but also external to the hospital with ministries of health and with different emergency operations centers. And the Ontario Medical Association has weighed in, and the CPSO has weighed in. Even my internet provider for my farm sent me a voice message saying that they're concerned about me. It's like, honest to God, like there's so many things that you're being pulled. It is very hard. And I think, you know, I'm always trying to bring it back to kind of the min specs. Like, what are the key things that I need to do? What are the key things where's my role in all of this? And how do I engage in those roles and pull myself back from other roles where there's other people handling that? Because there is, certainly in the hospital sector, there is a fair amount of, I'll be blunt, there's a fair amount of panic going on at this point where people are really worried about 100 different things. And I need to be informed by what's going on, but I don't need to jump into the details about how many masks we have. I just need to know where are we. I don't need to count them myself, for example. So there's things like that that I think, trying to keep yourself sane is very important. And the other thing that I've done, frankly, is, as you probably know, I'm being hammered by the media a lot to give different opinions, and I've been very clear where I'm setting boundaries around that, and so I'm making it very clear that after 7 o'clock at night, I cannot talk to you because I need to be able to zone out for an hour, because the day starts at 4:30 in the morning, and ideally, people would love it to go 24 hours a day, 7 days a week, and it's not possible to do that. So trying to set boundaries around my time and trying to keep a sense of humor and be calm to the people around me. And if they're calm, I'm going to be calm. So that's all part of that leading self piece.
Great. Yeah, thank you. And I hear setting boundaries as a priority, and as an occupational therapist, by training that whole balance, I fully understand that, searching out balance for sure. So we know that as leaders, it's really important to define your values. And one of the reasons why is that in a VUCA world, volatile, uncertain, complex, ambiguous, those values are what ground you in the work you're doing and as things are evolving. And we say that in the best of times, but now I think we're, essentially we're in the worst of times. And how do you use those guiding values or your principles in dealing with the crisis?
Yeah, that's a great question. And I think, when you get into crises, people really look for that. They look for some really guiding core principles that are going to help them get through this. Like, I want people, when I'm communicating with them, I want them to feel that they can trust me, that I'm not lying to them, I'm not misleading them. If I have no clue what's going on, I say, sorry guys, I have no clue what's going on, but I'm trying to figure it out. I mean, here in Ontario right now, in the last 24 hours, has been a massive scramble where we're being told by the government to send all of our healthcare workers home who have traveled. Yet, if I did that today, that would shut down our NICU, our ICU, and one other service, I forget which one. Anyway. The point is that what do you, how do you deal with that? And I need to be very clear with the doctors I'm communicating with that this is a mess. I get it's a mess. I get you're stressed. I get you're frustrated, as am I. My job today is to try to figure out what the hell's going on so that we can find our way forward. And so I think that value of being honest and transparent, not misleading people, I think is very important in times like this. I think people need to know that you're worried about them, that you care about them, that you empathize with the situation that they're in, because our healthcare workers are about to be put through the ringer, and letting them know that you're there for them as much as you possibly can be, to be honest and open, and if things look bad, to tell them things look bad, and really follow those values, hopefully the whole way through. But it's one of the things that kind of grounds me in a way, because there's so many details flying around and you can get so caught up into the weeds with so many issues, and being able to bring it back into more of a values-based discussion where it's about, I'm telling you these things because transparency is one of my values. I need to tell you what's going on. I think is very important. Otherwise, you feel like, honestly, like a ping pong ball on the ocean, and you're just getting bounced around everywhere.
Right. And you can feel the shift, and just in what you're commenting there is the shift from leadership, from this hierarchy of the leader knows everything, follow this super leader, to really flattening the hierarchy to let's work together, transparent, authentic leadership, and having everybody contribute. Yeah,
and at the same time, developing a command and control structure. So it's a bit of a paradox, right? It's like, at some point you need to make a decision, and this is the decision we're making, but I want my decision to be as informed as it possibly can be by the people who I lead, up until the second we have to make the decision. I need as much input as I can possibly get. And the paradox is that, of course, when you get into an emergency, we're not a democracy anymore. And so that's the hard part.
So it's balancing the two styles of leadership, really.
Yeah.
Yeah. Yeah. So we talked a little bit about engaging others, so we can move into that and talk about how you're communicating. Like, what are your, how are you communicating? Is it working? Would you do things differently? Is there too much from different sources?
Oh yeah. The part of the communication piece is challenging because we have, we'll have people that are bringing up systems issues and they're emailing me as their chief of staff to ask systems issues. And then there's other people who are emailing me because their sister just got off a flight from Cancun and they want to know what the sister should do, right? And so there's that whole range, and I'm getting emailed, I'm getting text, I'm getting phone calls. And it does start to get to be too much because I really do want to respond to people because this is an important thing for them. What I've actually had to do in the last just 4 hours or so is actually deputize one of our other doctors here to work with me so that she can deal with these very specific travel related, can I work, where do I get a swab kind of operational questions, because I found I was getting dragged into the weeds with that. And the other thing that I've been doing from the very beginning was back in January, actually, we started sending around updates to all of our staff, medical and non-medical, about high picture, where's this going? What does this look like? And I think that was helpful because about 7 weeks ago, my emails to everybody started getting a bit more ominous. And I said, the way this is looking, we're going to be hammered this spring, and we need to start talking about that openly, being prepared for it. I didn't get into details about ventilators and hospital beds, but it was more, this isn't going to bypass us. We're going to be part of this. The world's going to be part of this. And so we need to start getting into that headspace that we're all going to be affected by this. There's no person, frankly, in Canada who's not been affected by this. Even if they don't work in healthcare, you're not going to Starbucks anymore the way you were, right? So all of these things are going on. And I think that high level communication helped. It started to fall off a bit in the last week because frankly, we kind of all know where we are now. Now we're getting into the more detailed communication and we're trying to send that out. The other thing we've done is we've shifted from individuals communicating into an IMS structure as of today, so that now there'll be one voice in the hospital that will be sending out all communications. I'll continue to work with my doctors behind the scenes, but when it comes to a very, firm pronouncement on we're doing X, Y, and Z, that's coming from the command center rather than directly from me. So I'm still trying to touch base with people who have my cell phone number. They're texting me, they're calling me, and I usually pop in and say just a few words like, hey, how are your kids doing? Because I heard they were sick last week, and I know you're off because your kids are sick, and et cetera, et cetera. I'm doing that as much as I can in between running to different meetings. But you can hear, even in the tone of my voice, this is hard. It's getting very hard to keep up with that pace. Yeah. And likely this is going to start to collapse down. We've even talked about me doing some brief video messages that we can blast out to people where I'm actually talking to you rather than sending you a text. So we're looking at that as well. But I'm still walking around the hospital meeting with different groups. That's going to get harder to do as well because they're not going to have time to meet with me. So it's evolving, and it's evolving by the day. It's funny how different it feels today than it did on Monday.
Right. Yeah.
And we still don't have any cases, right? The surge has not happened yet it feels so incredibly different already.
And it's different from even when we planned this last week, that.
Well, exactly. Like I thought, oh, sure, I'll be fun. We can do this and it'll be great. And then, like I said, honestly, I think one more day and I wouldn't have been able to actually do this anymore because I'm getting pulled into so many operational meetings.
Now, just you had me thinking back when SARS happened. I was a frontline clinician and I was pregnant and I was terrified. I worked in a hospital. Yep. I was going to work every day, but of course worried about my unborn child and exposing that. And I'm just wondering, are you supporting your team who then supports, are you helping them or with the engage others, the coaching conversations and reminding them to be leaders? And how do you talk to people about that? There's almost two questions there. How do you talk to people who are afraid both for themselves in healthcare, but also supporting your team who then supports the lines to lighten your load?
Yeah, no, those are both good points. And definitely I've had a number of one-on-one conversations with clinicians who are frightened.
Mm-hmm.
And, you know, it's the message I can give them is I don't give them blind reassurance, because that's not possible, right? I can't say everything's going to be cool. We'll have enough masks for everybody for the next 50 years and it's all going to be fine. You can't give messages like that. And so I am being honest, and I'm explaining why I think we are as safe as any hospital in North America here in this particular building, and the planning that we've done. And the reality is, it is what it is, and we're going to see a lot more. We're going to see a lot more cases. I've had a number of groups of doctors who have been particularly frightened. Not surprisingly, groups that are going to deal with the brunt of this in the emerge, the anesthetists, you know, managing airways and things. The respiratory therapists are another group that I've chatted with a fair bit. And so I'm doing that at the same time. I'm speaking to their leadership and saying, you know, this is what we've got to do, and I've got your back as much as I possibly can. I can't pull masks out of the air for you, but I'm doing everything I possibly can, and we're very aware of these different issues that we're working on. So it really is trying to send that message from, you know, my position through the chiefs, through other leaders, and just saying, like, we're in as good a place as we can be. And so we need to accept the fact that this isn't going to be perfect, but we're in as good a place as we can be. And when we compare to other places, we're probably in a better place than a lot of other places. And I always hold out a sliver of hope that with the social distancing we're doing, that the predictions that we're talking about 2 weeks from now will be worst case scenario, and they won't be as bad as we're talking about. But I'm also making it very clear that I'm not counting on that. And we're going to muddle through it together.
Right. Yeah. Do you think any communication, like what's missing in communications? Is there things that can be improved upon, like in reflection? You know, I don't know.
Yeah, I mean, I think it's a good point. I think that there's almost too much communication going on right now, and that there's a lot of noise. Like I was joking, I don't need to hear from my rural internet provider that my Wi-Fi is going to be okay. Don't care, right? I don't need that. Yeah. I don't need emails from my bank telling me that they're there to lend me more money, right? I don't need any of that. Fortunately, Air Canada has now stopped with the, you know, travel vacation thing. I'm not getting those anymore. But I mean, so there's a lot of stuff outside of work which you're being bombarded with, which isn't helpful, and I've just tuned all of it out. But even within work, I mean, here in Toronto, it's a bit of a nut house. I mean, we've honestly got communication from probably 6 different governmental bodies who are not necessarily coordinating and who may occasionally contradict each other. The OMA hops in there, the CPSO hops in there. It's almost too much. Right. And, you know, we've been saying for the last couple of days here that moving to a more IMS structure, which is really much more command and control, and actually communicating very clearly with not so many voices would likely be very helpful. The other thing that's happening at the same time, of course, which I didn't have to deal with as much during SARS because we weren't as connected during SARS, but the other thing we're dealing with now is every doctor is emailing and texting every other doctor in the known universe to get protocols from everywhere, which is good because we're learning, but at the same time, we're also making assumptions that if X hospital did this, then what we're doing must be wrong. And it's actually creating a lot of anxiety at the same time. Not unlike, I think, social media in general can create anxiety in people. And so the communication one is tricky. You need it, you need a lot of it, but it needs to be careful, or you can actually, I think, sometimes make things worse.
So a message for those on the webinar would be having, you know, just a bit of advice is to funnel messaging as much as possible within your own control. And then there's some learning on the systems level around this funneling of information that can be built.
Yeah.
That's helpful. And are you doing anything to engage you've spoken about talking about them to teams, being there for teams, and how are you engaging them?
A variety of methods. Sometimes it's plain old email because they're all over the place and they're busy, and I don't want to pull them into. We already have enough teleconferences as it is, and if it's something that's not urgent, I'm communicating by email. because otherwise we're just pulling people into teleconferences right, left, and center. And you and I both know that a lot of the time spent in teleconferences isn't necessarily useful time. And so I would rather give them a moment to think about what I'm asking them to do or what I'm saying, and they can respond by email. We are obviously texting with each other as well. We do have the teleconferences. We also have face-to-face meetings, but as of last week, we're all keeping 2 meters apart from each other, which it's very funny. If you think about the pace of this, last week, that felt really weird. And this week it feels like, why are we face-to-face at all?
Mm.
So it's really moved very, very quickly.
Very quickly, yeah. And that poses unique challenges. And when we're talking about communicating and engaging others, it's changing the face. Everything we've learned is, you know, face-to-face whenever possible. Yep. And those kind of conversations. So we're really turning around our skills. And do you have advice for people on how to engage remotely?
Well, that's it, right? Body language is 90% of your communication. So if it's all by email, so I'm very careful with emails I send that I'm speaking in full sentences. I'm not using block caps. I am thanking people. I'm being courteous. I'm intentionally behaving like I would behave anytime.
Right.
Even though what I want to say is, tell me how many doctors we have tonight for the ICU, period. Right. But that's my little bit of body language, even within my emails, that I'm trying to communicate in a way that isn't conveying panic.
Right. So it's a thoughtful approach to communicating virtually.
Yeah.
So moving into the achieve results domain, we've got hospitals to pivot very, very quickly in an unprecedented way. How are you keeping up with the changes?
You know, I started bringing this up about 2 weeks ago. I said, we have to decide as an organization what's a priority and what isn't. And things that were a priority 2 weeks ago are no longer priorities. So, you know, so first of all, making time to deal with this stuff you have to pivot to. What can we give up today so that we can work on this new work? Because, you know, cultures in healthcare are often, you know, what can I add to your plate? And then you'll keep all the other stuff too, and we'll see how long it takes until you collapse. You know, that we can't do that. So I've been very vocal about that. I've definitely stepped out of probably my traditional role as a chief of staff. I get involved in all sorts of stuff where I have an opinion. And that's one I feel very strongly about. You know, what are our goals and milestones for the next 3 months? Don't care. We'll deal with COVID-19, right? We just had a conversation today about our board meetings. We will inform the board, but this is not the time to be talking about our, you know, refreshing our strat plan, for example.
Right. Yeah.
So we're putting all of that stuff aside to really focus in on the information that's coming in. And now that we have our IMS structure, that actually really helps with that. And so the information's all coming in, it's being disseminated to people. We just finished our meeting before this call, actually, and then we'll have another one late this afternoon to talk about what have we learned today, where are we going forward. It's that control what you can control, and we can control how we meet and what information we get and how we disseminate the information. So we should do that. I can't control the ministry. Ministry can't control the ministry. There's, you know, there's all this stuff going on, but we can at least control our part of it, and we should do that.
Now, in terms of setting targets, do you set them in a pandemic? Do you set where you want to go and what you want to achieve as a hospital?
We do, but it's all COVID-19 related.
Yeah.
Right. So it's, how do we keep a resilient staff? How do we keep this place running probably at 140% capacity? How do we do that? How do we keep our staff safe? Those are all the questions that have replaced the usual questions. And the one thing I will say, having gone through SARS, is, you know, at the end of all of this, when the dust settles and it comes time around to figure out your finances and you realize you blew through $15 million that you weren't planning on spending, we all know that our governments are well aware of that. And certainly after SARS, there was a precedent set here in Ontario that, you know, we needed to keep track of our costs, but now is not the time to worry about our costs. This is an emergency. And so we do what we need to do. We track it all, and there'll be a reckoning at some point in the future.
A thought that a question that occurred to me is when you talk about the really resilience of the staff, there's protocols in place for physical safety. Are you thinking about the psychological safety and well-being of the staff? I'm sure you are, but what, can you make suggestions on what the thinking is?
I think that's a really important point. And I would imagine most organizations have been focusing on the physical to start.
Yeah. Yeah.
And, but there definitely are some very anxious people out there. And I don't think we've done enough, to be honest with you, at focusing on the psychological safety of people. Because we've been so caught up in the logistics and the volumes and the numbers and the planning and all of that. And
understandably, right?
Yeah, well, of course, right? But that psychological component is going to be huge. And in a way, all of the planning we're doing right now, once the cases start to come in, we've kind of done our physical safety planning. Like the rules aren't going to change much anymore, right? Once you get into the thick of it, the rules are the rules. And that, I am hoping, is a time where we can really focus on people's mental health in terms of keeping them feeling like they are able to come back to work tomorrow.
Thank you. How are decisions being made with respect to services and other competing priorities? There's still people who have had strokes or other health needs. Well, how do you make those decisions?
I know, and it's a bit of a mess because we can make our decisions internally. The doctors occasionally make unilateral decisions. We've got the medical associations that are weighing in on what they think is appropriate, and we've got various governmental bodies that are weighing in on what's appropriate. And so to give you one little example might be scaling back elective procedures or scaling back clinics, right? There's arguments to keep them open. These are people who need care. And why are we shutting them now? We don't have cases. We don't have a surge in cases yet. We know it's coming, but why are we shutting them now? On the other hand, we're using up PPE all over the place.
All right.
And are we going to have enough people? Like, why are we doing this? And so we've tried to come up with a happy middle ground there where, we're rapidly moving to virtual. We're rapidly triaging patients to say, can I just put off seeing you for 6 months? I did that in my own clinic on Tuesday. I still do clinical medicine. And I sat down with our nursing team and went through everybody for the next several weeks and basically came up with the min specs, right? How are we going to, who do we have to see? Who can we see virtually? Who can we put off? And those were the 3 categories. And we worked through all of it. So there's all of these competing things and they change.
Right.
And so literally we would have a communication from external saying, keep everything going. And 48 hours later, the communication would be, no, scratch that. We're now saying you should scale things back. And so part of my communication to my doctors is you're going to feel like a yo-yo over the next few days, and you're going to get really good at rolling your eyes, but it's going to constantly change. And until we finally settle in on what we're going to do, sort of the night before the battle, you've done all the planning you can do, and here it comes. Once we get to that stage, a lot of this bouncing around will likely stop. But right now, it's pretty intense, and I just keep apologizing, trying to use my sense of humor and say like, yeah, it's a total mess, and and we'll figure it out, and it's going to change every day, which I also got used to during SARS. It changed every day, as I'm sure you remember.
Yeah. So it's almost like the definition of adaptive leadership in fast forward, right? Adapting, changing.
Yeah, you're actually adapting by the minute.
Right. Yeah. Any advice for people to keep their sanity, to keep order in the mess?
The advice I give myself is really keep looking at the big picture. Why am I here, right? I'm trying to keep physician services running. I'm trying to care for our patients, and I'm trying to keep people as healthy as I can. And everything else is kind of less important than that. And just be prepared for things to constantly change, right? So don't get too comfortable in whatever decision you've made, because either you may change it because things have changed, or somebody external to you may change it. And that's the norm. And so don't get too don't get too caught up in, I can't stand the constant fluctuations, because you just kind of have to let them wash over you in a way.
Mm-hmm. Okay, thank you. Moving into developing coalitions, how is your organization partnering with others?
Oh yeah, there's a lot of that going on. There's a lot of that openly and a lot of that clandestine. Just everybody's talking to everybody about everything. And so there's official planning tables. There's also conversations that occur offline. So that is one thing I would say about this, which is actually it's actually quite nice to see, is the amount of communication between healthcare organizations is astounding. Everybody is talking to everybody about what are you going to do? What are we going to do? We're always looking for ways that we can come up with one voice, because again, we're trying to funnel that message. Mm-hmm. That didn't happen during SARS. We really didn't talk to each other very much, right? Maybe the CEOs chatted, but here there's a lot more of that going on. I think it's just because the world's just so much more connected now than it was 17 years ago.
Mm-hmm. And how are you receiving this information, making decisions, distributing education on the decisions? Like when you're working with partners in the community, how do you take that information and then disseminate it?
Yeah, I mean, it's coming in through email, and then we're sifting it, and then we're deciding, we're typically not sending around these big, thick government documents. We're sending around a synopsis, right? As of today, we're doing this. And so we spare people the 17-page document that came with it, and we're just giving them the 4 sentences. This is what we're doing. And again, we're spreading that in various ways, but most of it's either through teleconference or through email, where we're getting it out to people. Mm-hmm. And we have had town halls as well, where we've invited people to sign on to teleconferences and things like that. It just gets hard after a while, because the people that are holding this town halls are always the same people.
Okay.
It's always me, it's always the CEO, and it just gets very tiring after a while, and people always have their detailed questions that they want to drill into, and we only have so much bandwidth to be able to deal with that. And so our IMS structure is now, I'm funneling all of those questions, and we'll be answering them as a group FAQ going out to the organization, because most of them are similar. Right. But again, that's go back to the earlier conversation about the boundaries, where you're trying to set limits on what you can do.
Mm-hmm. Now, and I'm thinking about, working with your leadership team, who then work with other teams around partnering, and how do you encourage them to build those partnerships with the community sector or whatever sectors that are in your wheelhouse? Do you encourage them? Do you empower them? What's your approach to that?
Yeah, no, they're definitely encouraged. I mean, some of this is externally forced on us, right? So we're brought to multiple planning tables, and we're being told what to do by various groups, but we're also being engaged by those groups. So we're doing it that way. But there's also a lot of reaching out to other organizations behind the scenes to say, hey, what are you doing about this or that? And how have you managed this? So that's very much encouraged. The trick is, as I mentioned earlier, if you have so many different groups doing that, and there's no way of kind of sifting that information coming in, you could have somebody's opinion from somewhere that spreads like wildfire, and before you know it, you've got large numbers of doctors who are very upset about a particular decision, and you're like, where did that come from? And then you find out after the fact, oh, it was an email chain that came from Dr. So-and-so who works over here, and blah, 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 blah. So sometimes it's not helpful.
Right.
But you kind of get the good with the bad, right? At the same time, we've been sharing for the ICU. We've got protocols from Seattle. We've got protocols from Italy. We've got protocols from a variety of hospitals within the city here. So that's really helpful. Mm-hmm. Mm-hmm. So it's a bit of good and bad.
Mm-hmm. Talking about the system, generally, COVID-19 is a massive system challenge. Yeah. How are you thinking about the system? And 2 parts to the question, within your own organization, but then beyond the 4 walls of your organization.
Yeah, I think that we're, I think that we're still struggling with that a bit because we're at that phase of this pandemic where we're still getting pulled in many directions and getting caught up in detail. And as you know, detail doesn't help so much when you're trying to deal with a system. And I think that you need people who do that, but that needs to be fed up to your leadership, who are then going to make broader systems decisions based on that information that they're getting. So they're kind of synthesizing it and then looking at it from a bigger picture. We're still very much pulled into micro detail, and that's part of our shift right now, is to move away from the micro detail. We have people who can do that, but we also need to empower them to figure out solutions for that area so that we can focus on the bigger piece. Mm-hmm. So, and I'm not being critical here. I think it's just the reality of an emergency like this. Every hospital is going through this. You can hear it in the voices of the CEOs that, some of them are caught up in extraordinary detail. Mm. And over time, we're going to need to back away from that. But right now, that's what we're doing. And then as the bigger system as a whole, that's a really interesting one. I've been trying to influence the system as a whole a lot through the media, actually, where about 2 weeks ago, I started hammering the message about social distancing to any reporter who would listen to me about how the time is now, now, do it now, right? And I have no idea whether me doing that helped or not, but it changed around the same time, so that's good. But, it's hard because the healthcare systems are so big and have so many parts, and there's so many people who have voices of authority in them, that unless you go to absolute command and control, which frankly, soon I would like us to probably do that. Mm-hmm. Unless you do that, all these different cogs are always going off in multiple different directions, and you do need to nudge the system towards whatever direction you need it to go in.
Right. What in picturing, a year's time from now, and maybe 5 years from now, yeah. What are your hopes for what we can learn from this? And, from a leadership perspective, as well as a systems perspective.
I mean, that's a great question. I think like every healthcare system, we focus on the now. We don't focus on the what if. We don't focus on the prevention. We have not adequately planned for an event like this. Mm-hmm. So, and that's all. I mean, that's just deja vu all over again, right? We say that every time. Next time it'll be different. Next time we're going to have stockpiles. And I think we did see some of that in Ontario where, after SARS, there definitely were shifts in the system that were positive. It's interesting, though, that some of those shifts that we created after SARS, we've kind of gone back to the old way of doing things again. We haven't necessarily continued to build upon those shifts. Mm-hmm. So that's interesting. And then I think that the other piece for the future is really the healthcare systems are so complex that allowing them to go in 100 different directions, especially in Ontario here, where we're right in the middle of a healthcare transformation and it's not done yet, and we've got even more people to check in with rather than less. That is almost impossible to deal with on the front line. There's so many different opinions from so many different groups. I mean, we've gotten emails from Cancer Care Ontario that contradict what the ministry is saying, and we've got stuff still coming from LHINs, even though we're not sure if LHINs are still a thing or not. And we've got stuff from the Ministry of Health, and we've got stuff from local public health units, and we've got the OMA, and they're all weighing in different aspects. If this was a war, we'd be in big trouble right now. Right. And so the military kid in me is very much at what point do we get to command and control here? Because this is nuts. Mm-hmm. We need to get control of what we're doing, and we need to speak with one voice.
Yeah. Thank you. We'll switch it over now to, I hear, Johnny, that this is a war. And I was thinking, we've got the VUCA world within the healthcare system itself and external in our environment with the virus. Like it's almost like exponential volatility. So we're going to open up Dr. Jaason Geerts, my colleague at the Canadian College of Health Leaders. He's moderating our questions, so we'll let, hi Jaason.
Hi there.
Would you be able to go through some of the questions that have been asked?
Yeah, thanks. And I think just as a very brief summary that does, Michael, a lot of what you've said has already answered some of the questions about the style of leadership. And I think in peacetime, we're quite critical of autocratic leadership, but in combat, that's exactly what you need.
Right.
And so I think what I've heard you say so far is what we really need from leaders is trustworthy, clear, consistent communication. This is what we need to do.
Yeah.
And one thing that came up in one of the questions that's interesting, so from a procedural point of view, that makes a lot of sense, right? If this happens, here's what we do. From the psychological point of view for ER docs or people who are having to, docs or nurses or other clinicians who have to make decisions that go beyond what they would have been doing 3 months ago. Who gets the ventilator, that kind of thing, turning patients away. You've touched on it, but could you elaborate a little more on how to kind of prepare people for that kind of psychological impact that's coming?
Yeah, well, I think, you're right. And I think having conversations about it and people are pretty aware of what's been going on in Italy, for example. So it's not like this is a huge surprise to them. I think what is a surprise is that we're actively talking about it here in Canada, right? I mean, we've been living in a bit of a bubble until 2 weeks ago where this was all something really scary that happened elsewhere. So I think there was that first shift. I think the other thing in terms of, the frontline staff is they're going to have to make calls and we have to empower them to make those calls, but we also have to support them. And so, for example, if we do get into battlefield triage in Canada, I don't want a lone doctor making those decisions at 2 o'clock in the morning in the emergency department. They have to be supported in that. And so one of the things we've talked about in pandemic plans for years is making sure that those decisions are collective decisions. We have a small group of people who are ready and in real time can help make those decisions because it's hard enough being exhausted and running off your feet and also at the same time making the biggest ethical decisions of your life. So they have to know we're there for them, and we empower them. They're the experts. They're the frontline experts. They're the experts at what they do, and we've got their back at the same time. Mm-hmm. And that's a really important message.
Are there, a great question was, are there tools or resources you're aware of to help with the mental health of health workers?
That's a great question. And I'll be the first one to say, I'm sure there are, and I have not had time to look for them. Mm-hmm. And so even in this conversation that we're having today is, I'm bringing this up at our IMS meeting this afternoon, which is who can we ask to start looking into that exact issue and how do we really tackle this? Because we've been so distracted with the day-to-day operational stuff that has not come up at our table. Mm-hmm. It's there all the time. We talk about, yeah, this is scary. People are going to have a hard time, but we haven't done anything about it. So I think that's really important.
Mm-hmm. One question, these are not in any kind of order here, but there was a question I think that a lot of people are wondering about the percentage of people who are contracting it from touching surfaces versus direct contact with a person who has symptoms or not, but has it.
Yeah, so that's a very direct infection control question, which is much easier for me to answer. It's nobody knows the relative contribution of surfaces to infecting people. Mm-hmm. But if I explain it this way, maybe it'll make sense. So when a person coughs or sneezes, it's those ballistic droplets that are following like a bullet. They kind of come right at you, and then they actually follow gravity and fall down. Those are carrying about 99.9% of the virus. And they need to impact your mucous membranes in order for the virus to then start to infect you. And so the advice I've been giving people is that face-to-face within 1 meter contact, within 1 meter contact, that's the really high risk time when you're with somebody sick and they're facing you. Mm-hmm. So first piece of advice I've given people is don't face people. You know, do it from the side. You can examine people from the side. You can do all these things to avoid that person's airway being right at you.
Right.
In terms of the relative contribution of this virus on surfaces and you touching that surface and then rubbing your eye or whatever, probably pretty small.
Okay.
That's probably not the major player. The major player is likely that direct spray onto your mucous membranes. And I say that because all the epidemiology thus far is really like close personal contact. And I would think that if this had a big environmental component to it, it would behave more like norovirus, which is you didn't necessarily have to be in the room with somebody vomiting and you still got it. And it's probably all over the place and it lives in the environment for months. We know that. With this coronavirus, it's relatively wimpy. It's an enveloped virus. It's living for hours outside the body. And just because you can detect RNA doesn't mean that it's viable virus. So I totally love all the advice about hand washing and stuff like that. That is very important. To me, the most important thing is don't be face to face with somebody who's sick. I'll give you an example. I mean, I felt weird, but I had to take the subway a week ago. I don't take transit anymore because of this, but I really didn't have any choice. I took the subway and I literally held on to the handle and faced the wall. Normally, human behavior when you're in an elevator is you all face towards the center or you all kind of face ahead. No, I'm the guy in the back facing the wall. And yeah, that looks weird as hell, but the point is that I'm definitely protecting my face from getting a direct splash doing that. And so that's the infection control advice I'm giving people.
I wanted to ask you, it seems likely there might be two phases. So phase one is crisis combat. We need to be ready. It's coming. And when it comes, we have to react. Yeah. Then phase two, I think that this is just my thinking here. It's not over, but we've got the immediate now. And now we still have to deal with the fact that there are emergency measures in place. We've still canceled clinics. I understand your focus now on the immediate, but moving to what do we do after it onsets and we've tackled the first wave? How do we move to the second?
No, that's a great question. And right now, that's a gigantic question mark, right? People don't know what the epidemiology of this is going to do. The only place we can really learn, only a few places we can really learn from, good and bad, right? So you look at what happened in Hubei province and in Wuhan. Wow, like they're down to single digits of cases. And truly, I don't think anybody understands. I don't think any of us understand that, right? Because if you look at the number of cases and you look at the millions of people who live there, there should still be 99% of the population that haven't been infected yet they were able to stop it. So that's a really interesting question for which there aren't a lot of great answers. Are they going to get a second wave? So they've shut everything down for 2 months. When they start to open up, is this going to spread again? Or maybe the spread's not going to happen so much because of the summer and that seriously wishful thinking that maybe this will die down in the summer, although nobody knows if that's true or not. There's all of these unknown questions and we don't know how long it's going to last. So could you have wave 1, 2, 3, 4, 5 every time you start to loosen off your precautions? Does it start to peak up again? These are all great questions. The only thing I can say that's fairly confident in is that each wave will likely be smaller than the next, just because you have more people who presumably have antibodies. And so there's a little bit less fuel for the virus to keep going each wave. But we don't even know what proportion of the population has been infected with this. So we don't have a sense yet whether for every one symptomatic case, there's 100 asymptomatic cases. That would be lovely because it would tell us that we don't have 1% of the population in Hubei province infected, we have 10%, maybe even have 20%. And that makes a huge difference in terms of how many waves and how bad this is going to get. So right now, to be perfectly frank, I think those of us who work in hospitals, we're having a hard time wrapping our heads around even the first wave.
Yeah.
And so, like, you know, as I mentioned earlier, and as Johnny agreed, right, this is a war. This is just our first battle in the war. And I don't know how big a deal this first battle is going to be. If it's the only battle, I don't know. So
And
that again, that sort of resiliency to just be open to all these different possibilities.
And as Dr. Bernardi said, we've heard on the news that the estimation of between 30 and 70% of Canadians could contract this. So
yeah, that's a
we
lot.
still sticking to those numbers? Yeah.
That's a lot. And that's just based on the fact that none of us are pre-existing immunity. So why not?
Mm-hmm.
Right? Why not 100%? Well, just because as you get close to 70%, it gets very hard for a virus to spread because most people have had it already. So it can't get going. So the spread starts to taper off around 70, 75%.
Mm-hmm.
But that's it, right? And at what point does a vaccine come into play here? And then that of course changes everything if you had an effective vaccine, but we're still many months away from that.
Mm-hmm. Technical question that are two questions put together. There's one person who asked, the community group in Halton is considering sewing cloth face masks in small batch production to supply workers with. And so that's one question. Is that helpful? And second, why are we using masks instead of the full PPEs that they're doing in China?
Yeah, so those are both great questions. You know, cloth masks exist. We still use them in healthcare. And if we run out of supplies, I would far rather wear a cloth mask than nothing. So I think that's a very reasonable thing to think about. You know, how do you launder them? How do you reuse them? All those questions would need to be sorted out. But I don't think it's that hard to sort that out. As I said, this virus isn't particularly difficult to kill. In terms of the full PPE, that's a much more nuanced answer, because although we see lots of really cool video from China with people wearing hazmat suits and Tyvek and they've got Papper hoods, vast majority of healthcare did not take place like that.
Mm-hmm.
Right? Most of the healthcare in China took place with nothing, which is why they had so many people who were infected early on. So that's the reality there. I would think that our PPE use is going to be far more consistent in Canada, where it's not just for the photo ops or whatever. We're using it pretty much everywhere.
Mm-hmm.
And I don't have concerns about the PPE that we've recommended in Canada. This is something that I've done for 20 years of my career, is looking at PPE and how viruses spread. So I'm not so much worried about that. I'm worried about the volumes of people that we could be seeing who are infected. And even if your PPE is 99%, if you're seeing hundreds of people, you can imagine that we're still going to potentially see if people get infected through their PPE.
Mm-hmm.
That's just a reality. And I'm not convinced that the full hazmat suit with the Tyvek suits with Papper hoods, the reusability of those and the potential to contaminate oneself when taking them off, that's been a concern for a very long time.
Mm-hmm.
There's also the reality is that, and I'll just be very transparent, we don't have them. We do not, there are not supplies of Papper hoods and Tyvek suits for every healthcare worker to wear them for the next 4 months. We don't have them. And I'm not convinced that they're the right thing to do anyway.
Mm-hmm. Another question, how close are we to a vaccine how close are we to a vaccine for this?
Yeah, over a year. And this is something that our dear friend, the president of the US, got a bit confused about a couple of weeks ago. So I'll sort of explain it quickly, but really they've been able to determine, the part of the virus that probably would make a good vaccine target. They could do that fairly easily, and that's actually moved at very rapid speed. And there's a number of organizations that are looking at that, and there's a number of prototype vaccines that have been created already. Fantastic. Problem is first you got to do a phase 1 study to show that, is this safe? You need to figure out the dosing. You need to figure out if it's 1 shot or 2, and then you need to figure out if it actually works. And each one of those phases is taking a few months to do. And so very quickly you get into 9 months. You've now got a vaccine that you've proven is safe, you know the dose and you know that it works. Now you have to manufacture it. And so the delay is, it's most people are saying, who know more about vaccines than I do, they're saying, we're looking at probably 14 to 16 months, 18 months before we would have a vaccine ready to start giving people. Mm-hmm. That's a long way away. And it is impossible to predict what the epidemiology of this is going to look like 18 months from now. If we've all had it by then, you probably don't need a vaccine because it's done. Mm-hmm. If we haven't, then a vaccine would still be very useful.
Thanks. 2 final questions. The second last one is this this level of heightened anxiety and tension, much of which is well-founded, it's not sustainable. So on some level, we need to be prepared and serious about it. But I think I wanted to ask you about the role of healthcare leaders in finding ways. You mentioned the use of a sense of humor, but intentionally saying we can't be hyper anxious all the time.
Yeah, no, you're speaking my language, Jason, because I've been hammering that point home at my hospital over and over again, that the healthcare leader is hero is going to get real tired real fast. And those people are going to burn out. They're going to get sick. They're going to lose their temper. They're going to not make good decisions. And so I have been hammering that home, that especially the really senior leaders who obviously out of a sense of obligation, they are looking after their hospital. They're going to be on 24/7 for 6 months. Really? Can't do it. This is where you have to trust the people that you've hired and the people that you work with, that while you're asleep, they're going to make the best decisions they can make. And once in a while, we'll make a mistake, but c'est la vie. We'll get over it. We'll figure it out. If we have to back up, we'll back up. But everybody needs to be able to take a break from this. Oh, here's our first. We only had one announcement during this entire thing.
Level 5E.
Wait for this to finish.
Room 542.
One more time.
Level 5E. Room 542.
Humber River Hospital has the loudest overhead announcements of any healthcare system in the entire universe. Nobody has louder announcements than us.
Well, it fits with our running theme of effective communication.
Exactly.
So I guess the last minute I'll talk about what we are doing next and what we can provide the people who tuned in. But the last question essentially is just your final thoughts on advice for health leaders who are doing their best in this VUCA situation. Yeah, final thoughts.
You know what? Doing your best is the best we can do, right? So this is not about being perfect. This is not about you being a hero. We're all going to make mistakes with this. And you just got to roll with the punches. You got to be flexible. You got to be bendable, or you're going to snap. And that we are going to need to get some downtime. I'm not talking about all your leaders going off for 3 weeks on vacation at the same time. I'm talking about a day when somebody can cover you and you can decompress. Because this is a long haul. This is not anything like SARS. For those of us who went through SARS, you could leave the hospital and SARS magically melted away because it was a hospital thing. And there's no magic here. This is, you leave the hospital and all you're confronted with is the fact that our cities are in partial lockdown. Mm-hmm. So there's no escaping this, so we need to make time to try to escape.
Mm-hmm. Okay. Well, thank you, Dr. Gardam. We appreciate your time so much, even though you're so busy. And now that you're once again a national, international celebrity, we appreciate your time. And I think at the college, we've devoted our careers to supporting health leaders. And I think in a time like this, leadership is absolutely essential. And so just to review what we've heard, the importance of communicating consistently to get through all the noise, to reassure people that with informed decisions, we are going to get through this and that we're together and you are being supported. So in that vein at the college, we will send out an email after and we'll thank you for coming to the webinar, but also ask you for what else can we be doing, especially in this time, to support the work that you're doing day in, day out. So thank you very much, everyone. Brenda, do you have any last questions or comments?
No, just very grateful, Michael, for your time today and best wishes and thinking of you through tomorrow. Glad we booked it for today.
Yeah, well, thank you. Talking about this has been somewhat therapeutic for me, so I think it's a good thing. Thank you.
Thank you.
Yeah.
Thanks.
And
Thanks
so
everybody for joining.
Thank you, everyone, and especially from the bottom of our hearts, thank you for all the work that you are doing for us and for those we care about. So thank you for today, everyone, and hope to see you another time soon.
Take care.
Thanks, everybody.
Bye.